welcome back. This is still April 24th, 1:53, House Healthcare. And we just have a couple people in with us today to walk through, not walk through, but go through some of the sections that have to do with sort of the reporting requirements and also as our joint fiscal Nolan Langwell lined up for us a little bit, maybe some of the budget asks that are not currently in the bill, but the budget, the ghosts of the budget requests of the past, but maybe somewhere else. And we have with us first the board, but I wanted to take a moment to introduce Rebecca Crow with us. And you can go ahead and introduce yourself and tell us what you do. And
Sure. So I'm Rebecca Crow. I'm a practicing geriatric physician in the state. And I'm also a health and aging policy fellow. There's about 13 of us nationally that work about bringing people who provide care at the ground level to policy making. So I'm doing my fellowship with Senator Welch's office. So thank you for letting me sit in today.
thank you. And where do you live?
I live in Norwich.
In Norwich. And you practice currently at
At the VA.
the VA. Great. Well, it's great to have you with us.
Thank you.
All right. Oh, thank you. So,
For the record, I'm Susan Barrett. I'm the Executive Director of the Green Mountain Care Board, and I'm joined by
Jean Stetter. I'm the Administrative Services Director at the Green Mountain Care Board. That means called back office
and Budget.
stuff, budgets.
And today we were asked to cover Section 11, which we're waiting on our General Counsel, Mr. Barber, to join us shortly on that. But we were also asked to cover section of S-126, I should say, so you know where we are. Section 14, 16, 14 and 16, which relate to reports on our progress from S-126, and then 17 and 18 are budgets, and maybe that's where Nolan would come in. I'll do the first two sections first, then you can let me know how to proceed.
sure.
So thank you, members of the committee and Chair Black, for letting us come in and discuss these sections. So the first section I will go to is section 16. I have my very marked up version of the bill here. So this is titled, this is regarding the reporting in the annual report and the Green Mountain Care Board's annual report about our progress, Green Mountain Care Board's progress on S-126, specifically reference-based pricing programs. So I'm going to go to the next section too, and then I want to talk to you about a proposal for 14 and for 16 and 17. So 17, so first of all, 16 asks us to report out our progress in reference-based pricing in our annual report. The annual report every year is released on January 15th. So this report would come out on 1/15/2026. And again, the language says the status of its efforts, the Green Mountain Care Board's efforts to establish methodologies for and begin implementation of reference-based pricing and development of global hospital budgets, and the effects of these efforts and activities on Vermonters and on Vermont's healthcare system. And then in section 17, section 14, thank you, Jean. I knew that wasn't right. I'm like, that's AHS. So section 14 asks the Green Mountain Care Board to provide an implementation report. And this says on or before February 15th, 2026. So I just want to give you those 2 dates. One says 1/1/1/15/26, and this says February 15th, 2026. So they're only about a month apart, exactly a month apart. And this is providing an update to the House Committee on Healthcare and Senate Committee on Health and Welfare regarding the board's implementation of this act, including the status of its efforts to establish methodologies for and begin implementation of reference-based pricing and development of global hospital budgets, and the effects of these efforts and activities on Vermonters and on Vermont's healthcare system. So our proposal would be that we do one or the other. My preference would be to stick with section 14, that for a couple of reasons gives us a little more time. So we may have more to report. And I think that would be a more effective way of communicating out the information. We often don't all have a chance to read everything that's in our annual report. So that would be my recommendation if you would be open to that.
The original language, the January 15th language, is that in the reference-based pricing section? Or is it not in this bill? That's just what's in statute?
No, that's section 16.
Oh, section 60.
Yeah. And I think what they were trying to do in the Senate was maybe streamline the reporting, but when I looked at these dates, I thought, okay, one is on 1/15. This would be 1/15/2026 for the annual report. And then the next month, we would then give you all an update. We can do both too. It's no problem. But
Would your recommendation be to essentially strike section 16 and turn it into 14?
yes,
Incorporate it into 14?
I think it's the exact same language and I would refer to the chancellor.
Okay. Well, we'll talk to Ledge
Replace-
Council about that.
Yeah, replace 16, that's the annual report section,
Mhm.
with 14.
Okay,
Question though.
yeah, of course. Go ahead, Frank.
It looks like 16 though, it adds something to existing statute about your annual report. So they could be merged, but we wouldn't just be striking it, otherwise we wouldn't get, does that make sense? Like it says in section 16 that we already have an existing law, a requirement for an annual report, that there's gonna be a G added in about methodologies.
Um,
And then in section 14, it's asking for a report on this one specific thing. So it wouldn't just be like,
yeah, I mean,
it would be more like striking section
Right.
14 and moving 16
Well,
into 14,
and I-
not striking section
and I
16.
guess, and this probably would be a question for Jen, would you want this report every
I
year
see,
in the
yeah.
annual report, or?
Does everyone see what I mean?
Yeah,
Okay,
I do.
I don't have an opinion. I'm just pointing out the
And-
mechanics, and Ledge Council can advise how to make it work, but
So currently in section 16, we're adding G to
yes.
the existing requirements in the annual report,
Exactly.
which would mean you'd be reporting it in January and then again,
Right,
you'd report the exact
Yeah.
same stuff a month later.
yeah, and that's the problem, is that,
Well, I just thought, and I'm happy to do it twice, it'd be likely the same exact context, but
but it's a redundancy.
it is a redundancy and the February date seemed a little better in that it gave us a little more time because this will take time to implement. So that's why I was structuring it that way. But the question, I think, and this is for Ledge Council, is do you want this in the annual report every year?
So what, yeah, I hear you. I just want to think this through in my head really quickly because I have the thought in my head.
Okay,
So would it be okay to add the G as starting in January of 2027, that this will be included in your annual report, but keep the February 15th of 26 to give you an extra month on it for 26?
that sounds great. to me.
Daisy?
Getting a message from Fremont Care Board that the Senate wanted you to make reference-based pricing updates as part of the annual report going forward after the first report back in February 2026.
So,
That's why it's.
So the
separate.
Senate wanted that.
Okay.
so we could take the G in section 16 and just have that begin on January 15th of 27?
That was just.
Yes. But yeah.
Yeah.
Okay. I'm sorry, did you have something to add?
You guys just, you
Makes sense now.
you just addressed it.
You did.
So, great. So, yeah.
So we'd like it included in your annual report, but the first year we want it a month
I'm
later.
giving you an extension the first year, yes.
So we're fine with that.
Okay, great.
And so then the other sections you wanted us to talk about was section 17, which is regarding positions and funding. And so this was removed, and this is where Nolan might want to come in, or Jean, this was removed on the Senate side. There's a lot of conversations happening over there in Senate appropriations. So I can maybe give you an overview of where we are today, where I think we are today. Does that make sense?
Yes. Has anything changed today from what you gave us this morning?
No.
Okay,
Is that the fiscal note
Talking
that,
about the positions,
is that the 6 positions?
yeah,
How many?
there's three in the budget, for the record, the whole line over to this well. So this bill had 5 positions when it came. Had 5 positions originally, the bill was passed, but the Senate appropriations only did 3. But there's already 3 in the budget from the GovRex, so 6 new positions around the 8. Oh, but not all for this bill. I talked about that a little bit this morning.
yeah, so we'd love to hear about the 3 positions, the contracts, and then the electronic hospital budget data and the asks around that. Specifically what you intend for these to be used for, what sections of the bill they kind of intersect with.
Sheet there. So, and Jean will interject if she has anything to add, that would be great. So, as Nolan said, where I believe we are today is we have in the governor recommended budget, there are 3 positions that were proposed by the governor for the Green Mountain Care Board. These are a financial analyst position, a quality position, and an access position. Those are the areas they would be working on. These are to shore up, these are for the work that we're doing today. This is not for anything in S-126. If S-126 passes, I'm sure that there will be work that's done amongst these individuals, but that is where the governor's recommended positions come in. For this position, for S-126, where we have landed today is, as Nolan said, there were 5 that the Senate proposed, and Health and Welfare proposed. And we went down to 3, and we are asking for a director of reference-based pricing, a project manager of reference-based pricing, and a procurement operational position for all of this new work.
What is that?
So that is, I'm looking at Jean. So we have Jean, so she is our budget director. She also runs the entire, so for instance, we just moved into a new office. We had to deal with FEMA because our office flooded. Jean and her team, which is a team of 1, so it's Jean and Tyler, did all of that work. She also works with all of our staff on any contract that we procure, any kind of an RFP. She also assists me in human resources. So this would help her office and me with this new work so that we can be as efficient and expeditious, is that the right word? Quick as possible in order to get this work done. Because when you're taking individuals that you're hiring for these technical positions on reference-based pricing, and you're asking them to work on the contract side, they will work on the content of the contract, but there is many layers in state contracting for the safety of our system. That is not the best use of those people. So that is why we are asking for this position. Initially, I think in the first version of S-126, there was a staff attorney, and our legal team, I can see him. He will join us shortly, I'm sure. Their team wanted more help to support this team in terms of the operations side.
Tucker?
Could you just give us some kind of an explanation? You have a director of reference-based pricing and a project manager of reference-based pricing.
Sure.
Can you tell me, like, in terms of responsibility?
Sure.
They
So
both seem to me to be administrative positions.
actually, both of them, in my view, if we can find them, if we do get the positions, would be very technical around reference-based pricing. So the director will lead the work building the methodology for reference-based pricing, working with stakeholders, working with our legal team on rulemaking. There are many, many parts to this reference-based pricing work. So that director will lead and be the project manager will report to the director. So both the director and the project manager will have expertise, technical expertise, but the project manager will assist the director in all of those layers of work in terms of, as I said, building the methodology, getting stakeholder feedback, working with our legal team on rulemaking so that we can coordinate all those parts.
So you have two project managers?
Nope, we have a director of reference-based pricing who will run the reference-based pricing program at the Green Mountain Care Board. And then we'll have a project manager in reference-based pricing who will support that work as well. And I think I'll add here, the board is not huge. It's bigger than it was when I first got here 12 years ago. But we are all nimble. I talked about Jean stepping in to do any kind of work that needs to be done. She became the FEMA expert over the summer to get us into our new office. We flex a lot in our agency because we need to, because we want to be lean and we want to be nimble, but we also have taken on a lot of work that that has not been resourced over the years.
Any other questions about those three positions?
Yes, how many are assigned to the Green Mountain Care Board now? How many people do you have on staff?
We have 30 people on staff. 33? That was 30. Oh, because we got the, we have 30, and the 5, you're not including the board
Oh,
members.
I'm sorry, it's
Yeah.
33, including the 5 board
Okay.
members. So we have 5 board members, so that leaves 28, which includes Susan, staff attorneys, and all of it.
And we just added, as you recall, well, last year, maybe you don't recall, yeah, but you might have heard about it. We had 2 people added through a fund, the prescription drug fund. I know I'm getting that wrong, but Kate O'Neill and Noah Montanaro, who work on evaluating state oversight of prescription drugs. So that's brand new last year.
And do I dare ask, what's your budget?
I'm going to give a gauge and then Jean is going to give me the exact amount. This
For
year,
personnel.
it's for everything, it's 9.9. And then next year, it's a little over.
Yeah,
We can get the exact amount for you.
I don't,
Right.
have-
It's
I can pull up the exact amount, but,
that's fine.
Yeah.
You get the picture.
and, just, so part of our budget, I feel compelled to say this each time, so we have about a $10 million budget. $500,000 is our contribution towards the healthcare advocate. And then in addition, the Green Mountain Care Board, we're honored to be the stewards of the healthcare claims database and the hospital discharge database. So we're honored to do that work. And, as such, a substantial chunk of our budget pays for maintaining, and servicing those databases. So,
Which they've heard about over the last couple of days.
yeah.
Could you just say that very first thing you said? X part of $1 million, I thought you said was for the healthcare advocate
Correct.
and legal aid?
Correct, yes. So,
What does he do for you? Oh,
so.
what does the
so-
office do for you?
So much, when before coming to the Green Mountain Care Board, I worked for the Department of Finance and Management. And at that time, the state pays for the healthcare advocate for Vermonters. So the state does. And there were multiple agencies that contributed towards the cost of the healthcare advocate's contract. I don't have the current number in my head, but at some point they consolidated the number of departments or agencies that paid. So the Green Mountain Care Board, we pay a piece of that. So we pay $510,000 a year to AHS, and then that goes towards it. In many ways, you could think of it like how we go ahead. No, I'm sorry. Thank you.
To simplify it, the Green Mountain Care Board is one of the agencies for which we fund the health advocate route. So they're not contracting with the health advocate. That's one of the avenues for how the state funds the healthcare advocate to do its work.
Why don't we just fund them straight?
I know.
Because you can't, they're not a state agency, so they have to be appropriated money to the State Department, and then they have to contract. They contract for the work. We can't appropriate directly to a non-state agency.
Leslie and then Brian.
Grants.
I'm trying to follow the money and I'm having a hard time. So why does it have to be so complicated? Or maybe it's not by your standards, but by my standards.
So just to step back, we can't appropriate, the state does not appropriate directly to private entities. We appropriate to departments and agencies. And then they contract or they do grants with also all the DAs and the SSAs and all that stuff. It's all through grants and contracts. We don't directly appropriate to. So the healthcare advocate is just one of those organizations for which the state.
They're the vehicle.
The Green Mountain
Correct.
They don't do anything for you.
No,
No, I mean, they're part of our, statutorily, I mean, they're statutorily part of many of our regulatory efforts, and they represent the consumer in that, but they do not work for us. That is correct.
part of the reason why, and correct me if I'm wrong, Gene, part of the reason why it goes to the board versus AHS
Yeah, that
is
was.
because we can get bill back.
That's right.
They use a lot of their budget through build back, and so we can use build back to help fund the healthcare advocate, so that we're only paying 40% of general funds towards it.
Huh.
So build back is this mechanism, DFR has it, the Green Mountain Care Board has it, it's a mechanism for which the agencies, departments can bill a regulated entity for the work of regulating them.
To pay a fee for being regulated.
Perfect.
Jean, I think Jean wants to add something and then Brian.
I just want to apologize. I didn't mean this to be the focus of the conversation. When Representative Page asked about our budget and our staff, the point I was trying to make is, we are absolutely an expense, and you can choose whether or not to keep us or to change, we're absolutely expense. And what I was trying to highlight is within that expense, if you take out the things that we are required to do and honored to do, it is actually a smaller pot of money. So I apologize for the bringing this all up. So
Hold on one second. I want Brian to ask his question.
Yeah, go ahead.
And then I have a question for Nolan, actually.
Okay.
So you get appropriated funding to pay for the Office of Vermont Health Care Advocate. And when you disperse that funding, does it have to go through an RFP process that Vermont Legal Aid applies for, or are they just guaranteed to get the contract and you're just a pass through of the money?
You know, that's a great question. And to correct, the Build Back statute for the healthcare advocate is actually different from our main statute. And it's lower than 40%. I apologize, I don't remember the exact number. I can research it if you really want to know. We execute an MOU, a memorandum of understanding with AHS. So we don't hold the contract. We, as part of our budget, agree, and the budget that we bring forward to you every year has $510,000 of like what AHS calls like their mixing bowl, our mixing bowl. We have $510,000 that you approve. And then we have this memorandum of agreement understanding with the Agency of Human Services Central Office. And so to the best of my knowledge, it's all like competitively bid and all the things from my past lifetime and work in finance and management. So, because that's part of state contracting.
Yeah.
Which, yeah.
So it's, so just to be transparent, then
Yes.
anyone could apply for that to be the healthcare advocate.
Yes.
It's not guaranteed to be Mike Fisher and his crew, and that they're winning this bid every so
Yes.
often through an open bidding process with standardized guidelines and criteria that people have to meet, and then you look at that and look at what they're offering, and you make sure it's all compliant, and then someone selects the bid. So someone could come in with a lower bid, and you can give them a chance. Someone could come in with a higher bid and get it still.
Yeah, because they have quality or,
Yeah.
you know, all the criteria. So that in some ways, what you're talking about goes back to like the request for that particular position. There's a lot of work to keep in compliance with the accounting, human resources and contracting parts of being a responsible steward of Vermonters' money.
I think it's important that get out there since we're talking about this. So because I think we've seen the same people serving in that role for a long time, but I think it's important for people to realize that that's not a guarantee and that they have to re-earn that contract, as well as what you just said, which is there's a lot of work involved when you're a government body trying to manage these kinds of contracts, because you have to hold people accountable. You have to, there's certain, and that this is not meaningless bureaucracy, that this is,
Correct.
these are steps put in place to ensure accountability.
Absolutely, absolutely. And I can just validate that. We recently had a small request for a sole source contract, which we never do. A message from Mike just popped up. So,
Listening.
the Agency of Administration walks their talk. They really put us through the rigor for needing to know why, you know, we think a sole source is best for this $30,000 contract. So it is real.
Yeah, there's a lot of work involved. I think that was the point. So I appreciate you
Thank you.
giving details.
And a lot of rules, as there should be.
I see you, Topper, but can I
Yeah.
ask Nolan my question?
Go ahead.
To the point.
my guest.
I just want to make the point. I have not seen numbers in years. However, off the top of your head, do you have a roundabout idea of how many billions of dollars we spend on healthcare in the state of Vermont?
I should know. It used to be, I want to say it's around 6 to 7 or 8, somewhere around between 6 and 8 billion.
And that was a couple of years ago, I think we
Yeah.
last saw.
Yeah, we're still waiting for the newest expenditure analysis.
So 33 people regulate probably close to $7 billion in our state
For $10 million, for $10 million.
for $10 million.
But we don't regulate all of it, for the record,
No, but
but a big chunk of it.
big chunk of it. And frankly, we're sort of asking you to take on a lot more in looking at the system as a whole in this bill. I just want to make that point. I remember when, I don't know if it was Owen that was up here, but the numbers of the people and the Public Utility Commission, which regulates public utilities and the resources that they have to regulate less of our segment of our economy than Green Mountain Board. So I just wanted to throw that out there. And Topper, you're.
Yeah, you just talked about how much work you had to do to make that thing work.
Yeah.
You got any other deals like that?
What do you mean? I don't understand the question, like,
Well, you're like the pass-through for
oh, that.
$100,000
Yeah.
plus dollars.
Yeah.
Do you have anything else like that?
Other-
Or it takes your staff to work on that?
You know, the only other thing would be, as Jean mentioned, we steward the healthcare databases.
Okay.
There's
Let me
nothing
tell you why I
else
asked
like
that
that.
question.
Yeah.
Last time I checked, the Green Mountain Care Board was supposed to be completely independent
Hmm.
from the state. Am I wrong in that? Did that change?
Correct. That has not changed. That has not changed. We are an independent board.
But you got a contract
We,
of money that your staff has to manage.
are you talking about the healthcare advocate? We do not hold the contract for the healthcare advocate. The agency of administration, or is it HS, I think? Yeah. We contribute to that, but we do not hold the contract.
So,
Yeah.
I mean, we're talking about an agency here that's asking for more people. And then, anyway,
Go ahead, Nolan.
No, go ahead, finish.
right, go ahead.
I was just gonna say, the issue is, there's only three branches of government.
Yeah.
So as an independent agency, they have to fall under one of them, so they fall under the executive branch. So even though they're independent in how they're structured, they are still an executive branch. They're part agency, still part of state government.
Okay, I'm okay with that. I understand that. But I also know that the healthcare advocate is part of the when budgets are being set, is allowed to ask questions, et cetera, in that process.
Yes.
So I'm trying to figure out, then maybe what I said in the beginning is true. All they are is a vehicle to pass the money through.
Yeah.
Yeah.
Okay, that's what I asked in the beginning, and
Sorry.
What, it's not a complicated question, just a clarification. That you're passing the money through, but are you also making the selection?
No,
So who makes the selection? Yeah.
I don't want to, it's not, it's the.
You can figure it out later if you don't want.
Administration.
It's Jen Kirby, I'm just gonna
Yes.
If you looked at H80, if you remember, was the healthcare advocate bill. The beginning of that whole chapter, the whole chapter in the statutes on Office of the Healthcare Advocate, and it is through a contract with the Agency of Human Services.
Okay.
That's who holds the contract.
Now, if I can also.
Who holds the contract with the Office of the Healthcare Advocate?
why do they have to?
That's what I'm wondering.
So if I can jump in, part of it, it's not, their whole budget is not through the Green Mountain Care Board. I think it's only the part that reflects their work as a party to insurance regulations and hospital budgets. So the part of their work that deals with being an actual statutory party to insurance rate regulation and hospital budgets, that part flows through the bill back of their office. The rest of the work that's not related to that does not flow through there. So that makes it clear. Sorry, the healthcare advocate. So it's not their whole budget, if I believe it flows to the Green Mountain Care Board. It's just the part of their budget for which they are a part of that work.
Could you ever say to the healthcare advocate, we're not gonna let you ask those questions.
Yes.
Because we just did a bill that made sure that the healthcare advocate had the ability to ask those questions. So why did we have to do that?
We have statutorily given the healthcare advocate a voice and a seat at all these tables.
You know,
And so the part of the healthcare advocate's office that supports that seat at the table, their budget is passed through the agencies that they have the seat at the table.
yeah, they got like 4 seats, 500 and some thousand bucks.
Well,
So anyway, I don't want to talk about it anymore. I think I know what's happening and that's fine with me.
Can I just share one additional follow-up thing? We talked earlier about how much time the work takes.
That's right.
The whole time that myself and Tyler spend on the healthcare advocate each year is probably 15 to 20 minutes. It is a very short amount of time to execute the MOU and then make sure that they're paid.
Yeah.
I understand it now though,
okay,
because you're chipping in some through the bill back, and that's why it's going through there. So it's like it's like everyone's throwing in money through all these different places, and then it's all flowing into this. I get it, sort of. Enough, but I'm tired of talking about it.
let's not talk about.
Yeah, it's
Opening this.
Let's not talk
It's like
about
we're
the
at family
healthcare
dinner
advocate
and we've
anymore
reached that
since
point. It's like-
he's gone.
Yeah.
He'll probably watch this back and see. Is this a good time to mention, by the way, that congratulations, H80 was signed by the governor yesterday.
That is a good time.
All right, moving on from the healthcare.
Great.
Oh.
Thank God.
Okay, let's,
We do have 2 more sections and then we can turn it over.
Okay,
And it should be
let's
clear.
go through those 2 sections and
The,
then.
just the contract money that was allotted through. The original S-126, it's now in the budget, so,
Okay.
um,
What is the envisioning of what these contracts are going to be for?
the first one is for reference-based pricing. So we would need a contractor to help set that. And that's for 500,000 one time. And then the second one is $150,000. I'll just read what it says in the bill because I think that is the most accurate way to describe it, and then I can talk more about it. It's appropriated from the Health IT Fund to the Green Mountain Care Board in fiscal year 2026 for expenses associated with increased standardization of electronic hospital budget data submissions in accordance with Section 4 of this Act. So the evolution of this language is originally there was language in 126 to set up what were called chart of accounts. Uniform chart of accounts. I look at my financial person to make the there's 14 very
Apples to
different
apples compare.
hospitals so that that our team could get a more apples to apples comparison. What our team realized is that would be a lot of work for the hospitals, especially for the smaller hospitals who don't have large financial and IT contract or staff. So our team suggested that we work with a contractor to build it on our side so that when they're submitting the data, we can make it as apples to apples as possible.
So rather than increasing their bill back, we're going to take money from the HIT fund to support them so that you all get the same data from
So it's more
hospitals during the hospital budget review process.
from each of the entities, yes. As similar as possible.
Yes.
That is it.
I get that. Anyone else have any questions about that?
That information is just one way from the hospitals to the Mountain Care Board.
When they submit their information regarding the budgets, it goes from the hospitals to the Green Mountain Care Board, correct?
And this individual is, I guess, coordinating all the data for you?
So we would hire a contractor to work on our system so that that information would be more apples to apples. When we get the information from the hospitals, we can work with a contractor to make that more apples to apples when we're analyzing it.
Save time in the future.
Exactly. We are really looking at automating as much as we can in all of our processes. Whether it's our hospital budgets or other work, and you just don't have to keep doing it. And it helps with the regulated entities as well.
Any questions about that other? You,
Well, I'm just thinking, why can't you just ask the hospitals to provide the data
We,
that you actually want in the manner that you want? So you don't have to hire an IT or electronic data person.
and we do that now. They provide very, very good data, but this would allow us to make it more comparable and automate and streamline it. And we wouldn't do it every year. This would be a one-time.
Jean?
I think, and I'm not a technical expert, what come to learn over time is we have very specific categories that the hospitals complete. Where there can be more shades of gray are in some of the operating or administrative expenses. So it's more looking at working with each hospital and teasing those pieces out. As we're looking more at the budget. People can just account for things differently, so it's working with each hospital to get those expenses more aligned. Yeah.
Brian?
What's the average cost of a tech support person like that approximately?
Well, this would be a contractor. I don't know. I'd have to find out. I mean,
Over 100,000 a year?
oh, for like if we were to
Yeah.
hire on.
Yeah, like the
someone,
general, or even just for the contract, we'll get the
Probably.
ballpark figure.
So we looked at, we worked with, the Senate on this
Yeah.
number, so this would be sufficient and,
What's the number?
we said 150,000.
Okay, and what's the approximate, like, what's the average yearly salary of like one of the upper executives in a hospital like UVM?
I think the
It's over five.
CEO is at 4 million, 3 million.
Yeah, so millions, right? So I asked that because if we put it in perspective, spending 150 grand on someone to help us get our data in order is nothing compared to what we currently allow executives to get paid, and there's many high-level executives in UVMMC, for example, maybe not all hospitals. So perhaps they could help us, figure out which positions of those we can eliminate and then redistribute the money to more people who are doing this kind of work to help the system save costs.
Is there anything else in the bill that you don't think is addressed by the needs that you have laid out for us?
We did pull back on the global budget position, so I should address that. We had in the initial bill out of the Senate, there were two additional positions to build global budgets. We felt it was more important to start with the reference-based pricing and then work towards global budgets in the future, realizing the constraints on the budget.
And that would involve us changing effective dates for some of the various pieces as it goes through.
It could, yeah. Related to that.
Tracy, did you have a question? I wasn't sure if I saw your hand.
I think I answered it. It's the change in that position is reflected in the latest joint fiscal note, right?
That's the most up-to-date one. I think it came out yesterday or today.
And S-126 is it's a bill that spans multiple years. It looks at multiple years. So really our thinking on that would be that the global budget work,
Sorry.
is deferred to a later time period. One additional note that's important is currently Vermont is a signer on the HEAD model, and we have cooperative agreement funds at the Green Mountain Care Board for development of global budgets. If circumstances should change on any of the parties' decisions on to continue in that agreement, and we lose those funds, we would need to evaluate our need for funds for global budget at some future point in time.
Yes, now we have.
Yeah.
Hi, Mike, are you there?
Hi, yeah, I'm here.
Hi, how are you?
Good, thanks. How are you?
Good. I'm glad you were able to get connected. I believe you were gonna talk about section 11.
Yes, section 11. For the record, Michael Barber, General Counsel for the Green Mountain Care Board. So section 11 of the bill would amend 18 VSA 9374 by adding a new paragraph to subsection I, and the new language would clarify that the board has the ability to share information, papers, or records that it receives pursuant to a subpoena or notice to produce with another agency as appropriate to the work of that agency, provided that the receiving agency agrees to maintain the confidentiality of any information that's confidential. We support this section. We would ask that it be expanded slightly to include not just state agencies, but state officers. So for example, the state auditor is not an agency, but an officer. And with that slight expansion, we fully support this section and think it would be helpful to have this ability clearly set out in statute.
Would you
That's all I
mind?
have.
Would you mind explaining to me what this does?
Sure. So we currently have the ability to subpoena information from persons, healthcare entities, facilities that we need to do our work. And we sometimes have a need or a desire to share information that we receive with others. So for example, the Department of Financial Regulation, Agency of Human Services are agencies that we work closely with and often want to share information with. And I expect that desire and need to share information is going to increase as we move forward with system transformation efforts, with working through the solvency issues, for example, that Blue Cross is experiencing. And it would just be, we think we have the ability to share information currently, but it would just be good and helpful, I think, to have that memorialized here in our statutes. And that's what this would do.
So this will help you work collaboratively, ensuring that all of our state agencies have the information that's needed, right?
Correct.
Okay. Any questions on this? All right. Well, thank you. Thanks for joining us.
Thank you.
Thank you, Susan. Yeah. Jean, where? Oh, there you are. Thank you. All right, Alicia.
Good afternoon.
Hi, how are you?
I'm doing well, thank you. How are you?
Good. So I think you were going to speak to 12, 13, and 15, as well as the appropriation pieces.
I am going to speak specifically to section 12. I believe AHS submitted a memo on the other two sections of interest. And I believe that AHS central office will be speaking to the budgetary components around appropriations.
Okay.
I'm also wanting to offer myself today, since I wasn't available last week when some of my AHS colleagues were here, to talk a little bit about Medicaid's current global payment structure and how we see that connecting to Medicaid global budget future state. If that is of interest to the committee while I'm here, I'm happy to do that. If you don't want to do that, that's also fine. But if nothing else, I can speak to section 12.
Absolutely, you can speak to that. Thank you, I appreciate it.
Certainly. All right, so for the record, Alicia Cooper, I'm the Director of Managed Care Operations for the Department of Vermont Health Access. Regarding section 12, both AHS and DVA are supportive of this reporting requirement. As you know, our healthcare system and our payment structures have evolved quite a bit in the last decade as Vermont has had consistent accountable care organization participation in various payer models. Now that we are in 2025, the final year of OneCare Vermont's operations, OneCare is beginning to wind down, and it will be important for us to have a shared understanding of what functions and capabilities the ACO offered that could continue to be valuable to our system in a non-ACO future state. As we're doing this kind of assessment, it's going to be important to think about these potential gaps from various vantage points. So for instance, the things that OneCare has been doing that are most valuable to a hospital are probably slightly different things than what they've been doing that have been most valuable to an independent primary care practice. And those will, be different even still from what's been really valuable to, for instance, the Medicaid program as a payer partner in these arrangements. And so I think this inventorying activity is going to be really helpful for understanding all of the different things that the ACO has been to those different parts of the system and what we are potentially losing versus what might be more shifting. So understanding what's lost versus what may have to be accounted for in different ways going forward. DVA's already begun doing some of this work from our specific lens. As you know, we have contracted with OneCare Vermont for the Vermont Medicaid Next Generation ACO program continuously since 2017. And so we have a good sense of the types of things that will no longer be available once that contract is gone. But we believe that this particular reporting requirement in the bill will help support AHS in pulling together that broader view, understanding it from not only the payer perspective or the sort of state of Vermont perspective, but also from different provider perspectives and other sort of key partnerships that the ACO has had through the years. The one thing that I would recommend on this section is updating the title. I think the original title was from when a prior draft envisioned other responsible parties for this reporting requirement. So at this point, I think the title doesn't currently align with the section content, but that's hopefully an easy fix.
I think we've got that.
So that was all I had on section 12. Happy to take any questions that you might have. And if not, I can sort of pivot to the other subject.
Does anyone have any questions around this? I think I just have, oh, I'm sorry, Brian, go ahead.
I came in another room because I'm having an allergy attack and I don't want to like sneeze and cough. Could this section be an opportunity to look at how we might replace the accountable care organization with some other finance structure that would provide health care as a public good?
I think the way that I think about this assessment is that, there are a lot of things that the ACO has either come up with as innovative payment models that they're offering to providers, or they're offering analytic solutions and tools that otherwise we don't have the capacity to do currently. And so I think it will give us the opportunity to figure out sort of what has been the most essential that we would want to maintain, and then to figure out how to prioritize replacements for those. I think what you're asking about is maybe even bigger than sort of taking the functions that have been high priority to date and thinking about what to sustain, and is kind of along the lines of, you know, in future, are there other organizational structures or relationships that we would encourage among different types of provider entities that would, you know, facilitate different financing structures? I think it's a great idea to think about that. I'm not sure if this report itself would get us all the way there.
But it might give us some information that we could use to look at a different way of financing providers the way that the all payer model did in terms of like global payments and et cetera. Okay. Thank you.
I'm curious about, I'm assuming that when we talk about retained capabilities, we're talking about sort of data collection, payment methodologies, sort of even intellectual property. Is that owned by the ACO, or because we essentially paid the ACO? I mean, this is explore opportunities to retain capabilities. Is it just for us to identify what we might want to retain? And if we did want to retain something, would we have to pay the ACO for that?
I don't think we would necessarily have to pay the ACO specifically, but I think, you know, chances are we would have to figure out how to financially support these capabilities somehow. And so, you know, for some things that the ACO has done, I think there's kind of an element of, you know, proprietary design that they have gone through. And so I don't know if we would be able to replicate it exactly. I think that's part of the assessment. We'd have to figure out how much of it is kind of shareable and extensible and maybe could move to, you know, some other responsible party. And I think we could also learn, you know, in this process, whether there are things that, you know, our providers would like to see happening in a different way. And so that we would be building out what would be ultimately a value to the system, not just sort of a one-for-one replacement if that's not meeting the need. But I think, you know, to your point, it might be a little bit of everything. I think there's some things that maybe the ACO has uniquely done because they are an ACO and because they've sort of structured themselves in a particular way that we would have to think about differently if we didn't have an ACO. And then there are other things where we might be able to think about it a little bit more straightforwardly in terms of a different party taking on activities.
Okay, it wouldn't be that this is proprietary information to them and they wouldn't let us see that.
I would welcome you to have a conversation with folks from OneCare, and I certainly don't want to speak for them, but I think they've been very willing in all of our conversations with them to share, you know, extensively as they're thinking about their own winding down of operations, because I think they understand too that there are things that as an ACO they've been providing for our provider community that have been valuable that we may want to figure out how to keep going into the future.
Great, thank you. Daisy.
If any of those were funded with state or federal monies, it can't be proprietary.
That's what I was wondering, is because, well, we didn't necessarily fund the capabilities of the ACO. We've funded sort of the release of, we gave them the money for them to be able to distribute, correct?
Yes, and I think that's a really important distinction. And, you know, just sort of speaking for myself and how I'm thinking about this reporting requirement, I think we would want to take a holistic look at the different functionalities that the ACO has offered to providers, to payer partners, et cetera, kind of regardless of how they were originally funded. Because as you know, the ACO's funding mechanism was a sort of confluence of different funding streams. Most of the funding that was coming from payers like Medicare or Medicaid were for the services that went to members, like sort of redistributing funds across the system, but the funds were for care. So the funds that went into some of these kind of value added functions that the ACO has performed were often coming from provider participation dues or from like reallocation of fixed payments to make sure that we could prioritize these innovative payment models that maybe moved funding away from hospitals and into primary care or things like that. And so there's a lot of different funds. I don't think we would want to exclusively consider the things that were funded by public funds. I think we would want to think about the full universe of activities, but be very aware that trying to replicate any of these functions outside of the ACO environment would take probably new money in most instances.
Any other questions? This? Okay, thank you. On section 12, any other thoughts to add on the other? And I do have I'm actually going to I'll forward to the healthcare committee the memorandum that we did receive from AHS regarding the other sections. I think that they weren't able to get somebody in here this week due to school vacations.
I don't think I have any comments on the other sections that AHS included in the memorandum, but I did want to share some information about Medicaid's fixed payments that we've been doing and how we see that conceptually connecting to hospital global budget future state. I can spend just a couple of minutes on that if that would be helpful, but I know that I wasn't available when you were reviewing earlier sections where this might have come up. And so if that's of interest, I can do that now.
Please do. I had forgotten that, and that did come up after you had left.
Okay. So I think this committee is familiar that DVHA has been implementing fixed prospective payments to hospitals through our Vermont Medicaid Next Generation ACO program, which began in 2017. In 2024, last year, we began a complementary pilot called the Global Payment Program, such that any hospital that opted in to the Global Payment Program, in addition to participating in the ACO model, would begin to receive fixed payments for the vast majority of their Medicaid revenue. The Vermont Medicaid Next Gen fixed payment and the Global Payment Program payments together were implemented in combination as a step toward hospital global budgets for Medicaid, but using what models we currently have. DVHA has been working on development of a Medicaid hospital global budget methodology. We began our thinking about hospital global budget methodologies kind of in tandem with the state's negotiations for the AHEAD model. And for AHEAD model participation, Medicaid programs are required to offer hospital global budgets that are aligned with the Medicare hospital global budget methodology. And so this work that we're doing now is enabling us to make sure we're in a good operational position for participating in the AHEAD model in the future. But kind of aside from the AHEAD model, we do feel like hospital global budgets represent an evolution of fixed payments for hospitals from where we have been to date with our ACO program. We feel that continuing to have these fixed payments for hospitals through a hospital global budget offering versus an ACO offering will allow us to keep a few key things. One, it will allow us to maintain revenue predictability for our hospitals. Two, it will allow us to keep having flexibility in service delivery and incentives for higher value care and population health for our hospitals. And it will continue to give the Medicaid program more budget predictability. And hospital global budgets are probably the tool that is going to be what we could best use to achieve these options in a future state when we do not have an accountable care organization. So I'm sure we could have a robust conversation on this subject, and I don't know if you have time for that today or if you'd like to do it a different day. But I wanted to at least offer that as sort of a brief level setting on where we are moving directionally in terms of hospital global budgets.
How many hospitals currently do you have on a fixed global payment?
So we have, I believe, 4 or 5, and I will need to check that number, hospitals that are participating in the Global Payment Program pilot, which is kind of an extension of our offering through the ACO program. So for those handful of providers, they're receiving a fixed payment from OneCare for all of their Medicaid attributed members in the ACO program. And then they're also receiving a secondary fixed payment from OneCare for all of their non-attributed Medicaid members. And that's the Global Payment Program component. So when you add those two things together, a hospital is essentially receiving fixed payments for all of the Medicaid members that they are serving, regardless of whether or not they are attributed via a primary care relationship through the ACO.
Do they receive Medicaid payment on a fee-for-service basis if they receive services at that hospital? Or is it all included in their global payment?
So for those hospitals, it is all included in the global payment. So essentially, fee-for-service payments are no longer happening for those hospitals, with a few exceptions for types of services that aren't included in our total cost of care definition. So to be really specific, something like retail pharmacy, which is something that UVMMC does a lot of, still happens on a fee-for-service basis, regardless of their other fixed payment arrangements, because pharmacy services are not part of our ACO model and they're not part of our total cost of care definition.
Go ahead, Tucker.
Could you tell us how the global payment was arrived at, how much they would get?
Yes, it's kind of a combination of things, and I will speak very high level, and then if more information is helpful, I'm happy to pass that along as a follow-up. The first portion, sort of the vast majority of the fixed payment, goes through our contract with OneCare Vermont. And so each year when the Medicaid program is setting rates for the ACO, we will look at our universe of attributed members. We will look at historic expenditure for that population, and we will set what we believe is sort of the appropriate projected amount of money for the services that the ACO is accountable for those members. And then we submit fixed monthly payments to the ACO, and then the ACO, from that larger pool of funding, makes distributions to all of the hospitals and the independent primary care practices that are participating in the CPR program that are sort of sub payments of that larger fixed payment. In terms of determining how much each hospital gets of that larger payment that Medicaid issues to the ACO, that really is subject to the ACO's contracts with each individual provider. So they're doing a lot of the determination about how much goes to each hospital. For the global payment program, we have identified the amount that sort of additionally goes to hospitals based on historic payments to those providers from Medicaid for the non-attributed Medicaid members. And so it's looking again at historical information about the population that's being served and the types of services that a provider organization is rendering.
So is it restricted to Medicaid individuals, or was it an average or something like that of all the patients that the
These
hospital
particular
serve?
programs that we have been implementing have been specific to the Medicaid population.
Okay, thank you.
And I had asked this question the other day, and I understand that today you were here to explain the hospital global budgets to us. I'm still confused as to if this is something that Medicaid or AHS is already doing and keeps rolling out to new hospitals. Why do you need an appropriation to do the work? Because you're already doing the work.
I will defer to AHS regarding the appropriations, but I don't believe that any of the appropriations were specific to implementing global budgets for the Medicaid program. And so I'll stop there, but I believe we are intending to continue on this path kind of regardless of what happens with this particular legislation and regardless of what happens with the AHEAD model, we are working toward implementing Medicaid hospital global budgets for the future.
They've asked for $250,000 over 2 years to support development of hospital global budgets or other alternative payment models for Medicaid. DVA intends to implement a Medicaid hospital global budget in January 26, aligning both the requirements of the AHEAD model and the commercial hospital global budgets proposed in this legislation. That's their request for something that they're already doing.
I will defer to the AHS and financial folks to speak to that component.
Okay. All right. We look forward to hearing. Go ahead, Leslie.
This is just a quick question. What happens if you have an outlier who might be diagnosed with leukemia or something like that? Greatly, vastly outspend the per member or per month payment.
So I think there's sort of what happens now versus what happens in the future state are possibly two slightly different answers. In the current model, we do have provisions where the ACO, which is accountable for this total cost of care, is effectively held harmless for those particularly high cost members above a certain expenditure threshold. And so that is a way that we can acknowledge that we didn't plan for having that much cost when we were setting the rates, and we're not going to penalize the system at full risk for an individual that was having those higher costs of care. But we do sort of build in the expectation that there are a certain number of high cost individuals each year. It's sort of baked into the historical experience, and we assume that it's going to be the case going forward as well. In hospital global budgets, it's a little bit different in terms of how you think about outliers and setting a predictable budget generally. But there are different types of adjustments in the methodology that would allow us to take into account things like the risk of the population and how that may affect their utilization of healthcare services.
So would that be fee for service?
No, not necessarily.
Any other questions for Alicia? All right. Well, thank you so much. Thanks for joining us today. And again, we apologize for the other day. Things went a little long.
No problem. Understandable. Thank you so much for your time.
Thank you.
Bye.
I think we're done for the day. So we could go off